All right, hi guys. My name is Jordan Gauthier. I'm a hematologist oncologist specialized in CAR T-cell therapy, and I've been asked to discuss the question is about how can we improve toxicity management in patients receiving CAR T-cell therapy for acute lymphoblastic leukemia. All right, so let's get started. First, I would like just to give a rough review or summary of what is the current management of the toxicities, of the main toxicities of CAR T-cell therapy for ALL. And then I will briefly review some of the investigational strategies that are being explored to either prevent or to treat patients with very severe toxicities. So as you guys know, there's the two main early side effects of CAR T-cell therapy are cytokine release syndrome and neurologic toxicity, also named as ICANS, for immune effector cell associated neurotoxicity syndrome. So I will refer to these two as CRS and ICANS. So right now, there's only one FDA-approved product for ALL patients with relapsed or refractory acute lymphoblastic leukemia, and the FDA indication is rather restrictive, and only patients up to the age of 25 can receive the treatment, which is tisagenlecleucel or Kymriah. And we are eagerly waiting for new other products to be approved, particularly for adult patients with relapsed or refractory ALL. At this stage, the current management for managing toxicities to manage CRS and neurotoxicity or ICANS are suggested by what we call the REMS guidelines. And obviously, every institution caring for patients with CAR T cells may have some variations across these guidelines. But overall, what is recommended to treat CRS is to intervene in patients that present with moderate to severe symptoms using a drug called tocilizumab, which is an IL-6 receptor antibody, commonly combined with some high-dose corticosteroids such as dexamethasone. Roughly the same recommendations apply to ICANS and is recommended in patients with moderate to severe symptoms to intervene with corticosteroids as well. There has been multiple grading system to quantify the toxicity of these side effects. And more recently, some harmonization efforts have been done for everybody around the world to use the same language. And these are the ASTCT criteria that got published in December 2019. And I encourage you to review these guidelines, particularly for ICANS. There is a new scoring system called the I-score that is very simple and very efficient at grading the intensity of the neurologic symptoms. So now that I've reviewed the current management of CRS and ICANS, I will go through some of the investigational strategies to mitigate some of these side effects. And I haven't really mentioned that these symptoms, particularly in ALL patients, can be quite frequent. The vast majority of patients that will develop any grade CRS in the 70 to 90% range, and with variations across different types of CAR T-cell products and clinical trials. We have approximately 20 to 50% of patients that will develop with severe grade 3 or above cytokine release syndromes. When we look at ICANS in general, the overall incidence of grade superior to 3 ICANS seems to be higher in adult patients, and up to 60% of patients with severe neurologic symptoms, and overall in the range of 20 to 50% of patients with this significant neurologic toxicity. So what can we do to try to prevent this? One of the first approaches that were explored was in the prophylactic setting, which is really to prevent by sort of adjusting or refining the dosing of CAR T cells. And two main approaches have been investigated. The first is to reduce the dose of CAR T cells in patients with a high tumor burden. So we could cause that as a tumor burden-based CAR T cell adjustment. And we have reported this approach in 2016 in the Journal of Clinical Investigation, where patients with a high tumor burden above approximately 10% of marroblast would have a 1 log reduction in the dose of CAR T cells. And we've shown that it led to lower rates of ICU admission in high tumor burden patients, lower rates of severe neurologic toxicity as well. This was obviously a retrospective analysis with some limitations and relatively small numbers of patients. Another very interesting approach is to do what is termed as split dosing, which is to fragment the dose of CAR T cells across several days. For example, the approach that was reported by the UPenn group and recently published in the Journal of Clinical Oncology was to administer 10% of the dose on day 1, 30% on day 2, and 60% on day 3, provided the patient does not have any signs of CRS or ICANS. And this approach led to lower rates of severe CRS in this study, but the rates of neurologic toxicity was not specifically reported in this publication. Now, I'd like to talk about another approach, which is really how the field has been spontaneously moving towards, is to intervene earlier, to treat patients earlier. And the fear initially was to blunt the in vivo expansion of CAR T cells by giving, for example, steroids, high dose of steroids early on, or to interfere with some cytokine pathways, such as the IL-6 receptor pathway with tocilizumab. But recent data have suggested that this might not be the case, and we may be able to intervene early in these patients without reducing the efficacy of CAR T cell therapy. So this has been approached by several groups. Groups from Seattle Children's, for example, assessed the use of tocilizumab for mild cytokine release syndrome. It was published in Blood last year in 2019, and it was a retrospective analysis. And this led to basically lower rates of severe CRS, comparable rates of severe neurologic toxicity, and importantly, comparable efficacy. Other investigators from UPenn looked at intervening with tocilizumab early on, particularly in patients with high tumor marrow burden, because we know this is a factor associated with severe toxicity. And in patients with more than 40% of marroblast, any fever would trigger the use of tocilizumab. And this was assessed in a prospective, non-randomized 2-cohort study, and showing the investigators showed very low rates of severe CRS, and they met the primary endpoint with less than 30% of grade 4 or above CRS using the UPenn grading scale. And unfortunately, the rates of neurologic toxicity were not reported in this abstract. Lastly, another approach to treat and prevent severe ICANS is to intervene early as soon as grade 2. And this was assessed in the ZUMA-3 trial recently reported at the ASCO International Meeting. And this was, again, an ad hoc amendment, and this was not a pre-specified analysis, but the authors observed comparable rates of CRS, but significantly lower rates of severe ICANS, and importantly, a shorter duration as well of ICANS in this pivotal trial. And in parenthesis, I think we're all in the community very excited and looking forward a potential approval of KTEX-19 for adult patients with ALL in the future. In the refractory setting, or in patients with very severe features, and in particularly HLH-type manifestations, a very promising drug has been anakinra, the use of anakinra. And we've seen a recent report by the IACH group investigating the use of anakinra in patients treated with CD22 targeted CAR T cells for ALL. Again, this was a retrospective analysis of phase 1/2 data after some ad hoc amendments. But in all patients, the use of anakinra led to resolution of the HLH-type manifestations. And overall, very mild neurologic toxicity was reported. In the refractory setting, options, there are currently no approved product or drug to really treat these patients, and the field has been somewhat challenged to offer good therapeutic approaches in this setting. There has been a recent case series report in 8 patients with very severe refractory ICANS or HLH. And these patients were treated with low dose of anakinra at the 1 milligram per kilo per day subcutaneously, and often associated with corticosteroids. And all these patients had presented with very severe grade 3 or above CRS prior to severe ICANS or HLH. They did observe some responses in approximately half of patients and recurrence of neurologic toxicity in one of the 4 responders. So this is about it. And I hope I gave you some of the key aspects of how do we manage currently CRS and ICANS in ALL patients. And I've tried to give you a taste of some of the many investigational strategies to treat patients with these severe toxicities after CAR T-cell therapy. Thank you.